We're going to start with Chapter 10, Airway Management. So as promised, everything starts with a review of the appropriate anatomy. And we're going to go through the entire airway anatomy, but as you can see right here, it's just a cross-section of what you're going to be looking at and the pieces parts that we're going to talk about. So the respiratory system is all of the structures, whether it's the ones you think about or those extras, that allow us to breathe, to take in oxygen and release carbon dioxide. We divide it into the upper and lower airways, and we'll even talk about upper airway obstructions, lower airway obstructions, that type of stuff. So some of the other structures that allow us to breathe include the diaphragm, and that's that bell-shaped curve muscle at the base of your chest cavity. You've got the chest wall muscles that both provide structure and allow the ribs to move in and out to make room for when the lungs need to expand. The accessory muscles, which we talked about, that cause us to understand that our patient is having difficulty breathing. And then there's some involvement in the brain and the spinal cord that allow both the muscles to move and for the brain to know that, hey, it's time to take a breath in. So your upper airway is the nose, the mouth, the jaw, the oral cavity, the pharynx, and the larynx. And we're kind of going to go through these in some pictures. Understand that the upper airway's function is to warm and filter the air. It allows us not to take in some of the dirt and dust and pollen, even though that may make us all sneeze. It humidifies the air, so even though it feels like it's super cold, in the middle of the winter, when you take a deep breath in through your nose, when it hits the lungs, it's actually been humidified and warmed. Too much dry air will dry out the airway passages, which is a problem. And the pharynx is where the nasal passage and the oral passage meet, and it's a tube from the nose and mouth into the esophagus trachea area. And this, again, is just another part of the passage, allowing it to match up. So here is that cross-section picture I promised you. You can see the nasopharynx coming in through the nose, meeting up with the oropharynx and going down into the laryngopharynx, or the larynx. So the larynx, of course, is where our voice sits. Again, a picture of the oropharynx. And not necessarily for the oropharynx, but if you look at this cross-section, you can see just how massive of a muscle the tongue truly is, and how this actually, why it serves as the biggest issue that you're going to run into in airway management sometimes. And then follow that down, you hit the epiglottis. So remember, the epiglottis is that leaf-shaped structure that is going to ensure that the air goes into the trachea and that the food goes down into the esophagus. Your larynx, where your voice, vocal cords sit, they are right there marked, and this is where the upper airway ends and the lower airway starts. So it's kind of that breaking point between the two. It's got the thyroid cartilage, which is anteriorly, which, as we talked about, front, back, anterior more towards the front of that structure. It is the cricoid cartilage. So when you hear people talk about needing to cric a patient, this is where they're cutting into the airway. And the only people who should be talking like that are paramedics. And then you go down into the lower airway from this point. So the lower airway's function is taking that oxygen that came in through the nose and the mouth and putting it into the lungs. And it includes the trachea, the bronchi, and of course the lungs, because without the lungs, you're not really breathing. The trachea is your windpipe. This is the tube for which all of the air goes down and the point at which it must decide if it's going to go left or right. That point where the trachea breaks from left or right and into the bronchi is the carina. I promise I've actually seen that on a test question before. Not necessarily one that I'm going to use, but it is something to know. The bronchi distribute oxygen into the lungs. As you can see from this picture, from the bronchi, you go into smaller bronchi, and then you go into the bronchioles. The bronchioles end at the alveoli sac. Alveoli sac are important, especially because this is where oxygen is transported. And this is where that gas exchange occurs. So again, another picture. In that bottom picture right there, you can, and both of them actually, you can see the diaphragm, but the bottom picture shows you what happens to the chest cavity when the diaphragm contracts. So when the diaphragm drops down or contracts, you're going to get the lungs to fill up. And you've got to remember that your heart also sits inside the chest cavity. We refer to that area that was just shown as the mediastinum. So this is the area between the lungs where you've got the heart and the aorta, those massive vessels. Your esophagus actually comes down in there, the trachea, bronchi, and nerves. So that area in between those two is actually pretty important. And when you've got trauma in that area, you've got a major problem. So, while it's important that we know the respiratory system, you have to understand that while your respiratory system can work, if your cardiovascular system isn't working, you've got an even bigger problem. Because remember, air goes in and out, but blood goes round and round. Well, if the air goes in and out and the blood doesn't go round and round, then we don't get that exchange of oxygen. Understand that when I talk about ventilation, I am talking about moving air in and out of the lungs. Ventilation does not mean that I am oxygenating. It does not mean that I'm moving the oxygen around the body. It just means that I'm breathing in and I'm breathing out. Understanding that inhalation is the active phase of breathing. Inhalation takes energy. It requires calories. This is the part where there is physical activity happening. It takes the burning of calories to take a breath in. So while you're sitting there listening to me ramble, sit up tall and take a deep breath. You know that what's happening is that your chest is getting bigger, that your lungs are expanding, and this is because there has been that contraction of the diaphragm and there is a change in pressure. So when the diaphragm contracts, the pressure in your chest cavity decreases, which means you are going to move oxygen in. As it fills the alveoli sac, that's where you've got that exchange of carbon dioxide and oxygen blood cells. Well, if you take a deep breath in, you are going to take a deep breath out. And that is because when the diaphragm relaxes and those chest muscles contract and your chest cavity changes to a smaller size, it's putting pressure on the lungs. Exhalation is the passive phase of breathing. Exhalation doesn't take any energy. So all those kids who play that pass out game, that choking game, hey, I'm going to hold my breath until I pass out. Well, what happens as long as the body is going to catch? What happens is that when you pass out, your body's automatically going to relax. And when the diaphragm relaxes, you're going to breathe out. And so that's going to trigger the brain to breathe again, as long as the brain is still working at that. So again, exhalation doesn't require energy. It's a passive process. It is where the diaphragm and everything relaxes, where the smaller thorax compresses air into the lungs, and it moves. But you've got to have all the parts. So your lungs may work, but if your trachea's got a problem, there's a blockage, there's a hole, then you're going to have improper. You've got to understand that ventilation is based on feedback from the brain. The brain reads the pH changes in the blood and the cerebrospinal fluid based on the level of carbon dioxide. So a lot of people tend to think that we breathe because we need oxygen. And really, we breathe because we need to release carbon dioxide. So when you've got your chronic obstructive pulmonary disorder patients, that's COPD. Don't you love how they use an acronym before they define it? Their problem is that they actually do breathe based on the oxygen levels. They are used to having lower percentage of oxygen. But all of those who are normal, healthy respiratory systems, they're breathing because their body has too much carbon dioxide. So, next let's talk about the actual oxygenation. So oxygenation is beyond ventilation. Ventilation, again, where we take oxygen in and out. Oxygenation is where we actually have that spread and of oxygen through our body. It's where we are exchanging carbon dioxide and oxygen onto the red blood cells. You know that in certain cases, such as confined spaces, mines, caves, that type of stuff, fires, you're taking air in and out. But if the oxygen levels are low, you're not going to have good oxygenation. Respiration is where you have that actual exchange. So ventilation is air in and out. Oxygenation is the blood getting that gas exchange. And respiration is where the blood goes round and round, excuse me, and where you end up having the gas exchange at the cellular and tissue level in the body. External respiration and internal respiration. Who knew they were a thing until you sit in the EMT class? External respiration is the level at which you are taking the oxygen in and out. It's where your lungs are filling. This is where the exchange of gas and carbon dioxide, of oxygen and carbon dioxide in your capillaries is happening in the lungs. So when I talk about external respiration, it's going to be the gas exchange occurring up in the lungs. Internal respiration is when that gas exchange occurs down at the tissues. So just like I can have ventilation without respiration or ventilation without oxygenation, I can have external respiration without internal respiration. So if I'm having a stroke, I'm not getting oxygen in my brain. That gas exchange isn't occurring at the cellular level in my brain. So I don't have internal respiration occurring there. So again, external respiration is when I am getting that gas exchange in the alveoli sac. And internal respiration is when I'm getting that gas exchange down at the cellular level. This slide's pretty obvious, and that is that all cells that need oxygen will die without oxygen. It's why we talk about early CPR. It's early recognition being important. And you can see that when you have more than 10 minutes of lack of oxygen, you're going to have irreversible brain damage. 0 to 1 minute kind of makes that heart irritable. It's why when someone's having a heart attack, when they've got a blockage, they're having chest pain. It's the heart's way of saying, hey, hurry up. Anywhere from 0 to 4 minutes, you're likely not to get brain damage. But when you hit that 4-minute mark, that's where you start to increase that probability that your patient's going to have brain damage. It's why when we talked about patient assessment, I told you it's important to make sure you're constantly checking your patient's airway. If they're conscious and oriented, talking to them so you know you don't want to lose precious time. So let's talk about the overall functionality of respiration in the body and what it is that causes us to breathe, to need to breathe. As I talked about a few slides back, you do have the need to breathe because of carbon dioxide. So what happens is there's some receptors, we call them chemoreceptors, in the blood. And chemoreceptors are going to monitor the levels of all of those items there, your oxygen, your carbon dioxide, the pH balance, and it's going to send that feedback and those levels back to the respiratory center. When there is a mismatch, when it's too low or too high, then we're going to have a fix. And you've got to keep in mind that air and blood must go at the same time. I've got to have air going in and out while blood's going round and round. If I take air in and out, but blood's not going round and round, then I'm losing that functionality. I'm losing those blood cells because on the next punch of the heart, blood cells that didn't get exchanged are moving on. And so now you've got less oxygen. Does that make sense? So if I take a breath in, but the blood's not moving, it's not going to exchange oxygen. If I take a breath out and then the blood starts moving, then those red blood cells that were sitting at the alveoli sac aren't going to exchange. And this is exactly what this slide says. See, even with recording slides, I'm still getting ahead of myself. When there is a mismatch of ventilation and perfusion, when I'm breathing more than my heart's beating, or my heart's beating more than I'm breathing, I am going to lack that gas exchange, which then is going to decrease the oxygen in my bloodstream, and I'm going to have carbon dioxide recirculating. This is not good. This is where we've got problems and where we start to show signs of low blood oxygen. So what happens that can impact our pulmonary ventilation, our external ventilation? Well, everything. Unresponsiveness, foreign body airway obstruction, trauma, an allergic reaction that causes swelling in the airway, an infection, pneumonia. I hate to bring it up since, it's the bad word nowadays, but COVID. These are all going to impact your patient's ability to bring air into the lungs and to have gas exchange. What happens in external factors associated with respiration? Well, how about bad oxygenation in the room that they're in? Again, any respiratory disorder or disease that's going to cause problems. So remember, a pulmonary embolism can cause problems getting circulation into the lungs, and that's a clot that's in the lungs. Pneumothorax is when you get air in the chest cavity on the outside of the lungs, and hemothorax is when you get blood in that cavity. Hemopneumothorax is when you have both blood and air in the chest cavity. And this is not in the lungs. What this does is cause pressure and doesn't allow the lungs to expand. In the lungs. Circulatory compromise could also be because I'm anemic. I don't have a high quality of blood, red blood cells, or I've had blood loss, or just that my vessels aren't doing what they need to do and I'm not moving that circulation.